I welcome you all today for this technical innovation session, or also call it as the Indian Jugaad session, where we are going to have a plethora of presenters and experts in the field of hernia today. The whole concept was evolved because we see a lot of technical things coming up in the field of hernia today. And by sharing our experience with our fellow surgeons, I think we can probably help shortening our learning curve. So this idea came to us, and then we felt that we should invite people from all across the world. And today we have got people from every corner of national and international representation. And we are going to learn some good techniques and tricks, which will help us evolve our practice better. And ultimately, I think this is all done to have a patient-centric approach where the outcomes definitely matter in day-to-day practice. So without further delay, I would invite our President of Hernia Society of India, Dr. Ramesh Agarwalla, to give his inaugural opening sessions. Thank you, sir.
Thank you very much. Thank you very much, Jignesh. I take this opportunity to welcome you all to another masterclass of Hernia Society of India. I welcome all the faculty, namely Nani, Professor Sardar, Gustavo, Rakesh, Jignesh, Tarun, Anmol, and all the other faculties and all the delegates to this webinar. The aim of Hernia Society of India is to propagate the art and science of hernia surgery. It's a very vibrant society. I would request all of you all to visit our website, Hernia Society of India, become a part of it, and join this journey of teaching and learning. This has been the brainchild of Jignesh, and I'm very, very grateful to him for coming up with such a wonderful idea, which is going to be useful to all of us. And Jignesh, Tarun, Anmol have really put in a lot of hard work over the last 1 month to put this up together. And I'm looking forward to a very, very exciting show. And I can already see so many smiling faces on my screen. Thank you very much, Jignesh, Anmol, and Tarun. Over to you, Jignesh. You have to unmute yourself. Jignesh, you have to unmute yourself.
Yeah. So thank you very much, sir, for those kind words. And you can see I'm so excited, that I have forgot to unmute myself. But so starting with the flow of the program would be that we have, first of all, our international experts. So we begin with Dr. Danny, who is a senior surgeon, a general surgery and the transplant department, lecturer in general surgery at the Sheba Medical Center in Tel Aviv University, Israel. Our second expert for today is Professor Sardar Naeem, Professor of Surgery, Chief of Laparoscopy Surgeon and Chairman, Japan Bangladesh Friendship Hospital, Dhaka. The third expert is Dr. Gustavo Carvalho, who is a General and Minimal Invasive Surgery, University of Pernambuco, Faculty of Medicine from Brazil. And our fourth faculty is Professor Rakesh Kumar Gupta, who is a Senior Consultant, BP Koirala Institute of Health Sciences, Nepal. Not to forget my two colleagues, Dr. Tarun, a Senior Consultant and Laparoscopic Surgeon from Gangaram Hospital, and Dr. Anmol, who is also a Senior Laparoscopic and GI Surgeon from Gangaram Hospital. We have really put in a lot of hard work over the last couple of weeks to consolidate and come to a great idea. So the flow of program would be that Dr. Anmol is going to share, and we are going to have it in 4 sessions. In each session, we will have 5 videos. So we have a total of around 20 to 21 videos which are going to play through. Per session, there will be a first presentation where the presenter will give a voiceover. Followed by that, we will have an expert panelist give his expert comments on those videos. So for all of you who are watching live as audience and delegates, I'll be very happy if you can mark your question for a particular presenter. If you have some query or something to answer, we will try to fit into the question answer session as and when possible, because time is going to be our constraint, but we'll see that we do justice. So without wasting more time, I would probably now tell Dr. Anmol to share his screen, and we start with the first 5 videos of the first session. Over to you, Anmol. Thank you very much.
So at the outset, I would like to thank Hernia Society of India and the leadership, especially Dr. Ramesh Agarwalla, sir, to providing us this opportunity to present the videos and be the moderators. So our first video is of E-optical access by none other than Dr. Praveen Bhatia, sir. And we all have learned from him, and he does not need any introduction. And the panel expert is Dr. Danny Rosen. Sir, it's all floor is to you, Dr. Praveen Bhatia, sir.
Thank you very much. ETAP access for bilateral inguinal hernia repair. Eyes don't lie. We strongly believe that we see everything and do the laparoscopic surgery. Now you can see that we are marking the skin with the skin pen, and then we are using the 12 mm port subumbilically for ETAP bilateral, for example, or on the left side if we have to go in for the left side. Now we carry on rotating the trocar after opening the lock. As we carry on going layer by layer, skin, subcutaneous tissue, camper fascia, scarpa fascia, and you can see the anterior rectus sheath and the rectus muscle. As soon as we reach the posterior rectus sheath, you can see that we change the direction of our, and then we do not puncture the posterior rectus sheath. In this whole of the exercise, we are not using the S retractors, we are not using the balloon dissector, we are not using any kind of material except for carbon dioxide. So with the help of tip of a scope, with the help of carbon dioxide, we are able to see the arcuate line, and God has created the planes for us. So if we are in a plane which is avascular, that is extra peritoneal, we will not cause any bleeding. Now you see that by syringe and needle, we see the GPS and then go in with the 5 mm threaded ports, so that these ports do not come in or come out every moment. The advantage of ETAP access is that we know that we are not hitting the vessels, we are not hitting the peritoneum, and that is the beauty of optical access, E-access. Thank you very much. Thanks a lot.
Dr. Danny?
Dr. Danny?
Very nice. And actually, my comment is first that I like to see things that are done my way. So I've switched to optical access about a few years ago. I was doing the open access and switched to optical access, and it works very nicely. I think we have to be more accurate about the terminology, because even though the margins are blurred, what is ETAP, what is regular tap? In your case, you're going below the umbilicus. I use the optical trocar very fluently. I decide about the location. I don't go all the time to the same location. It really depends on the habitus of the patient. And sometimes I go near the umbilicus, sometimes I go a little above. If I see that the distance is too short, then I go higher. So the margins between tap and ETAP are a little blurred, but the idea to go directly with the camera, I think it's a very good idea.
Danny, as I mentioned, especially for example, even if we have to make the port higher up, then we go with the same method. We have seen so many people using the finger stall or the finger and then going behind the rectus muscle and dissecting and causing some ooze. Our thoughts are that even if we have to go higher up, subcostal region with the ETAP entry, then the chances of causing any injury to the posterior rectus sheath, to the rectus muscle, to the bleeders will definitely be reduced. So that is the advantage of eyes don't lie.
Yeah, I perfectly agree, and that's the advantage, that you can choose the correct place. You don't have to go every time to the same location. It really depends on what you're about to achieve.
Sure.
And the panel expert would like to comment? Dr. Gustavo, Dr. Rakesh, Dr. Vignesh, Dr. Naeem, anyone?
I think that's a wonderful opening, and Dr. Parveen Bhatia, as usual, has always been a great opening batsman. Yes, any comments, Dr. Gustavo? You want to say something? You can unmute yourself, please.
Okay. My very, very small mini comment is ETAP is very, very special technique by my friend Georgie. and it makes possible for you to see well when you have large trocars like 5 and 10 millimeter instruments. We have not used ETAP because we go always from below the umbilical port and umbilical side downwards. So we don't need so big dissection because we use very small instruments, what we call mini tap or combined technique. That's the only key point. But if you want to use regular instruments, ETAP is really good because you do not fight with the image. You do not have image clashing with the instruments. That's the small comment.
Sure.
Okay. Thank you. Thank you very much. Can you go to the next one, Tarun?
Next video. So next video, I invite Dr. Pinak, a very versatile surgeon from Chennai, who would be talking about his PTP modified ETP. And Dr.
Good
Gustavo,
evening, and thank you for this opportunity. So this is P-TAP or the perfect view tap. So conventional tap has the problem of less space, difficult to manipulate. Once pneumo is there is loss of space. And if the umbilicus is placed low, it becomes a problem. So to tide off this crisis, Dr. Dias invented the E-TAP access, which gives a quite big area of dissection. My improvisation was to move it to a bit lower level near the umbilicus so that we get a perfect view. We don't need too much. And like as Dr. Gustavo said, the E-TAP, the amount of dissection I felt was too much for a regular hernia. Yeah, if it's a very big hernia, definitely E-TAP is my procedure to go. But if it's a normal regular hernia, then doing the E-TAP amount of dissection, putting 4-port, it was not necessary. So what I did was just migrated the optical port and entered as Dr. Praveen Bhatia sir has shown. It's almost similar, and you get a perfect view of what is needed. You don't dissect extra. The advantage is that you don't lose space even if there is a small puncture. And the amount of dissection is neither less nor more. And I feel that it's a perfect view of both the myopectineal orifice. So I felt it to be labeled as P-TAP. The rest of the dissection is almost the same. So once you have done adequate dissection, you can place a adequately sized mesh. So this is the closure of the direct defect with the pseudo-sac plug. And then you place adequate size mesh. So that my take is like it involves a lesser amount of dissection. Visiport entry makes it faster, and it has almost a similar advantage of E-TAP with one lesser port, and there is no loss of pneumo. So all the credit goes to the inventors like McKernan, Dr. Dulok, and Philip, and Dr. Dias, who have given us this nice avenue for repair of inguinal hernias. Thank you.
thank you, Dr. Pinak. Dr. Gustavo, your comments?
First of all, can you hear me well?
Yes,
Yeah,
sir.
yes, sir.
Okay. First of all, I would like to congratulate in the amazing video and very, very clear view, and you can understand well the concept of the tap and the E-TAP. Second, if you use this kind of space, and some people can be bothered with another umbilical, because when sometimes these small incisions close to the umbilical site got retracted, the patient looks like two umbilicals. So if you can work with a smaller space like you have done, you can just access from the umbilical port. You do a small subcutaneous dissection from the umbilical port, and you can already place your trocar. Especially if you have an optic view, it's very, very easy. We have done it so many times.
Yeah, actually, I do only if from the symphysis pubis, I need at least anything between 15 to 20 centimeter, depending on the size of the hernia. So if I have a 15 centimeter, it's a small hernia, I go through the umbilicus, means by the side of the umbilicus. But if I don't find that umbilicus is low placed and I need to go a bit higher, then I choose this technique. And if I am dealing with a very big hernia, then conventional E-tape and placing 3 other forts to help me manipulate with larger hernias is my thing.
And one very, very small last comment, I guess you missed Professor Jean Duluc, the very, very first pioneer from all TEP. And Professor Jean Duluc have described it, unfortunately, in French in 1991, just 2 years before Makana, the TEP access. So maybe we should remember him. The small penguin is very, very big surgeon, although small size surgeon. And I think if you can imagine that you don't need so much space, you can just use the umbilical site because it's already a scar, so you don't make another scar in your patient, especially if you are dealing with women or somebody who really are willing to have a better cosmesis in the surgery. Because
Agreed.
some people also is willing to have a better cosmesis, not only the effect of the hernia correction. Okay, thank you so much, sir, for your video.
Yeah, thank you.
Yeah, Dr.
Yes,
Rakesh, you want to
Danny
comment?
wants to make a comment.
Yeah, if I may add something very small, the umbilicus is not one location. It's actually a circle. So you can use the lower part, the upper part. You can go through the umbilicus. What I usually do is I go on the side of the umbilicus from the inside outside. So you don't hardly see the scar after that, but you are higher than the infraumbilical. So you still gain 1 or 2 or 3 centimeters from the same location. Very similar to what Gustavo said.
Amazing comment, Danny, especially for extracting some organs. Umbilicus is wonderful because it's just a scar. In the end, you have just another scar.
Yeah, I also agree with Gustavo, because Gustavo loves umbilicus to use the first stroker, and he goes through the umbilicus. But Pinak, you have shown a very, very beautiful video, and also I should congratulate everybody because it is a great start with Parveen Bhatia. He's a very popular name in Bangladesh and has shown a lot of surgeries before in our country. And actually, I like Pinak's one because he is changing the position of the stroker depending on the size of the hernia. If he needs, well, he can put another stroker and go for a bigger hernia. But it's a good idea. For a small hernia, you can really go like that modified E-tape. Yeah, that's great. Thank you.
Thank you.
Great.
So I think we have limited time, so I think we should move to the next video. So next video is a bottoms up TAR. It's by Dr. Mukund Khaitan, who is a surgeon in Gangaram Hospital, Delhi. He's our colleague and very popular in AWR, abdominal wall reconstruction circle. Dr. Mukund, all floor to you.
Who's going to be the judge for this?
And his judge is Rakesh Gupta. Panel expert is Rakesh Gupta.
Dr. Rakesh Gupta is going to be the expert for this. Dr. Mukund, over to you, please. Thank you.
Thank you, Tarun. Thank you, Jignesh. And thank you, HSI, for giving this opportunity to present my work. Can I have my video, please? Yeah. So while doing a bottoms-up TAR, one has to go lateral to the inferior epigastric artery, dissecting into the space of Bogros, which is a known space for those who are doing a TEP or TAPP repairs or laparoscopic inguinal hernia repairs. But here the caution is like, rather than remaining in a pre-peritoneal space, we enter into a pre-transversalis fascia plane where we see the bare fibers of the transverse abdominis muscle. And once we go from below upwards up to the level of the arcuate line, one have to dissect between the transverse abdominis muscle and the transversalis fascia. And as soon as you dissect from lateral to medial side, dissecting away the peritoneum and the transversalis fascia, one have to divide the posterior rectus sheath that comprises of the internal lamella of posterior lamella of the internal oblique muscle and the aponeurosis of the transverse abdominis muscle from below upwards fashion, and taking care that while doing a lateral dissection, we have already dissected down the peritoneum along with the transversalis fascia. So the chances of puncturing or buttonholing of the peritoneum doing a transverse abdominis release is minimized. So here you can see that the transverse abdominis muscle fibers are bare, and we are dissecting from lateral to medial side first. That is, we are dissecting the plane first and then dividing the transverse abdominis muscle or the posterior lamella or posterior rectus sheath. So this is a sort of a reverse TAR, there we are dissecting first and then dividing the fibers of the posterior rectus sheath medially, but then while dividing the posterior sheath, one has to be very careful to prevent injury to the neurovascular bundle, which is of utmost important, because if we are going to do that, then one will lose the neural supply to the medial myofascial compartment and can have a long run laxicity of the anterior abdominal wall. And once we have done this lateral dissection, here we are doing a bottoms up TAR in a patient with a subcostal hernia. So we have done up to the level of the subcostal, and then we'll go upwards doing a top down TAR, and then we'll connect this plane. So here, once we enter into this plane, we can go laterally as far as up to the psoas muscle. But here the catch is that if you are in a pre-transversalis fascia plane, why I'm emphasizing more again and again? Because if you are in a pre-peritoneal plane, the chances of puncturing peritoneum is very high. So you should see the bare fibers of the muscle superiorly, anteriorly, and the peritoneum along with the transversalis fascia below. And once this is done, you can see that we have reached the sac area, and then we'll do a top-down TAR, and then we'll connect the TAR planes from behind the sac area. Thank you for your patience.
Thank you, Dr. Mukund, for very nice presentation and very nice video you shown. Maybe you have to put some, what was the exact hernia defect? Is what's the advantage of the bottom up TAR? Because we know the first abdominis muscle is much more better visible in the upper part, and in the lower part it's quite thin and aponeurotic. So for the beginner,
the bottoms of TAR is more easier for a beginner. Why? Because everyone is very well versed with the TEP and TAPP approach, where they are already dissecting into this pre-peritoneal and pre-transversalis fascia plane. So you just have to go lateral to the linea similaris, dissect in that plane, see the transversus abdominis muscle above, and see the peritoneum along with that cobweb appearance of the transversalis fascia below, and dissect from lateral to medial side, come up to the level of linea similaris, so that you are sure that the peritoneum has gone below the level of linea similaris, where you have to divide the linea similaris, and then one can divide 5 millimeter medial to the linea similaris, so as to prevent injury to the neurovascular bundle and opening a peritoneum over there.
Thank you. Very, very nice presentation, Dr. Ketan.
Okay, sir.
Yeah, so I think Tarun will move to the next video because the time constraint. Yeah, let's move to the next video. Thank you.
TP indigenous balloon by a GI and a pediatric surgeon, Dr. Keyur Yadnik from Surat, and Dr. Naeem is the expert panelist. Dr. Keyur, yours.
Hello, am I audible?
Yes, sir. Dr. Keyur, you are audible.
At this point, I thank Dr. Ramesh Agarwalla, sir, Dr. Jignesh Gandhi and team for inviting me for this fantastic opportunity. Now, balloon dissection in TEP space is not a very new thing, which is done with this PVD balloon, and it is quite available since many years. Now, the issue was that the PDP balloon was a bit costly. So I basically learned my balloon dissection technique by Dr. Nayan Swadhya. Now you can see here that this is a principally simple birthday balloon which is mounted on the suction cannula, and this is the tip. This is a part of the TOR set which is fixed with the BP cuff. So gradually, in a controlled fashion, you can inflate this balloon, and this good quality birthday balloons are equally good, but the precaution is that it is a blind procedure. So in TEP space, it is fine. See, you can here see that anterior rectus sheath is cut, the stay sutures are taken, the finger dissection is done in the retrorectus space, followed by blunt trocar dissection, and the device is inserted into the retrorectus space. Now, balloon is inflated in the TEP space, and which is hold for around 5 to 7 minutes for hemostasis, which gradually opens up the cave of Retzius and partly the lateral Bogro space. Now, this is a very nice technique. You have to just see that the you should be able to feel the rectal muscles, and you should be able to see the equal distension of the infra-umbilical anti-abdominal wall, and just wait for 5 to 7 minutes, and that's it. That gives a very good dissection between the anterior and the posterior layer of the fascia transversalis, and opens up the TSP space in a very nicely. You can see here what we call as a White House sign. It is when the balloon goes between the two layers of the fascia transversalis and opens up, and you are able to see the both pubic rami bones very clearly. Gradually after this, we put our two midline ports conventionally, what we do in a routine TEP surgery, and we complete the TEP dissection of both lateral spaces, dissect the sac, and then put a 15 by 12 mm size mesh. Either you can take sutures from that midline ports, or you can use a tacker also. You can see here very nicely the mesh is lying in the lateral space, and we have to keep in mind that the mesh crosses in the midline, and gradually you have to finish this procedure. This is a video which shows when the balloon is slided a bit on the left side, so the left-sided dissection is more. You can see here that the cave of Redges is open more on the left side, and the left space of Bogro is also dissected a bit. But if you see on the right side, the right-sided TEP space is compressed but not opened up. So this is a very typical situation which many of time you'll end up when you dissect with the balloon. So after putting the two working ports, we have dissected the left lateral space.
Here we are short of time. Q,
yes,
if you can just wind up, because the technique is about the balloon. Thank you so much.
So we have dissected that lateral space, and thereafter dissected the sac. And the first and the far important point which comes there is how to enter the undissected plane. Undissected plane on the right side should be assessed by what we say as hugging the roof. When you hug the roof, you usually enter that TEP space without entering into the peritoneum. And the same way, what we follow the principle is follow the light. You are always right. You have to find out the cobweb appearance of the TEP space, and thereafter you can complete your conventional TEP dissection. And in the same way, and complete your putting the mesh and dissecting out completely, and that will include the that will complete your procedure. Now, what are the troubleshooting or the complications what we have gone across during this many years? So we are doing this procedure since around 2003 to 2004. Complication what we have faced yet are we have gone into wrong planes. At times we have done small and large peritoneal rents also. You can have a bare recti or infra-epigastric vessel, but we have not seen any infra-epigastric vessel tear, no bladder injury. If the balloon ruptures, you have to find out the piece of the balloon and match with the primary one, whether there is one piece or two pieces, so that you should not leave a latex material inside. And one should be experienced in doing TAPP and ETAP, both of the procedures. So if you end up with some complication or issues, then you should be able to complete the procedure laparoscopically rather than converting into an open surgery. Thank you very much.
Thank you, Dr. K.
Yeah, thank you. Yeah. Okay, I was just wondering how do you sterilize this balloon, the common balloon and the pump? And of course, you talked about the burst. It might burst. And
yes, valid question, sir. We are sterilizing this whole device with ETO sterilization, and to everyone's surprise, you will not get a perforation in the balloon. Initially, we were thinking about it, whether will balloon get ruptured or get crumbled or useless, but it is not happening. We are
especially I was worried about the surgical emphysema if you produce out of the bursting this kind of balloon.
No, sir.
They're inside.
During the TEP dissection, as we all know, the TEP space is connected up to the mediastinum, and in subacute plane also it goes very much far away. So I don't feel that balloon dissection will give rise to some subcutaneous emphysema. If
just a last question. Can you use some kind of transparent balloon and go with the camera inside?
You are absolutely right, sir.
So that you can have a better selection of spaces and frame.
Absolutely, absolutely. We are trying to have that kind of local balloons, but the issue was the size. The balloon, what we were getting, transparent balloons here are very huge one. So we had initially tried, but the balloons were quite huge. So we are trying it off. And people are also in past, people have tried to use this balloon in ETAP ventral hernia surgery, which we don't recommend because this is a blind procedure. So if you use this same balloon in left upper quadrant TEP space formation, then you may unknowingly rupture the linea seminolaris, and that is the precaution what I recommend to everyone, that one should not try to use this balloon in creating ETAP space in ventral hernia surgery. We have used this balloon in retroperitoneal dissection also. We are used in ETAP inguinal approach also. And this is our outcome, sir.
Thank you. Thank you very much. That's a good indigenous balloon.
Thank you.
Yeah.
I think let's go to the last one of the session one.
So,
so this is going to be a video on, Anmol, you want to introduce Tarun?
Yes, sir. So the next video is by Dr. Tarun Mittal, who is a senior consultant at Sir Gangaram Hospital. He's secretary of the Delhi State chapter of HSI, and he's quite a dynamic surgeon and a senior to work with. And the moderator for this session will be Dr. Ramesh Agarwalla, sir, and Dr. Jignesh Gandhi. Over to you, Dr. Tarun Mittal, sir.
So as you know, for any inguinal hernia repair, the main parameters which we have to control are the chronic groin pain and recurrence. These are the two parameters. So to have lower recurrence and to avoid chronic groin pain, we have devised this technique of mesh fixation in large direct, mainly indirect, but also in direct hernias, in which all the four edges of our meshes are secured and fixed. So Anmol, can you play?
Yeah.
So after dissecting the myopectoral orifice, and then we, after unrolling it on the floor, we do it with unrolling on the floor with 5 centimeter lower margin fixed with the sutures, and then we cut those sutures and then we unroll them. So now what we do in large is just keeping the lower edge fixed and keeping this, make this upper edge also fixed, palpating the anterior superior iliac spine and go above it. Initially in my learning, people were doing it without unrolling it. So we started doing it after rolling it, so that we are always above the anterior superior iliac spine and the iliopubic tract line, so that we do not entrap the nerves. So this third lower two are fixed. First is in the space of ridges. The lower lateral is fixed at the space of Bogros. So now the upper medial edge of both the meshes, what we do is by the upper trocar, the middle trocar, we catch hold of both the mesh edges, and slowly we start, after we have caught hold of those meshes, we start desufflating the abdomen. So we have fixed this edge also, so the migration of mesh into the defect decreases. Thank you.
Thank you, Tarun. That was nice. Ramesh Da, you want to make any comments?
No, excellent, Tarun. I also follow this lateral fixation, and I do it exactly as Tarun does it. So
Tarun, only thing which I would add on is one should always stay about 1.5 to 2 centimeters away medial to the ASIS, because we all know that this is the place where the ilioinguinal and the iliohypogastric come from the retroperitoneal membrane into the groin. So you have put up a very valid point for the audience. This video is a very nice depiction where you can mention that don't stay 2 centimeters close to ASIS, because this is where you can have a damage to the ilioinguinal and iliohypogastric, even if you're doing a laparoscopic repair. So that was a wonderful video. And I think, Anmol, we come to the end of the session one. It has been a fantastic round. We've seen some beautiful videos, all related to the groin hernias. Let us start with the session two now. And once we have the sessions too, while it is starting, the audience, I would be very happy if you have any questions related to any of the presenters, please jot them down and put it up on the Docplexus, and we will be deliberating them at the end once we get time. But I'm seeing a very nice deliberation happening. So Anmol, can we have the screen for the next presentation? Yes, over to you, Anmol. And Tarun.
Gustavo had a question. Gustavo was raising his hand.
Yes.
Yes, Dr.
Not
Gustavo,
exactly
yes.
a question, but a small comment on this video at first. Congratulate, very nice idea on fixation, but we have been following Professor Jean Duluc since 1991, and Professor Jean Duluc claims that fixation of the mesh is not only unnecessary, but can give some problems for the patient. Since have you explained that you can have bleeding, but also you can have more pain when you just fix the mesh. About 4 years ago, an elegant paper from Cristiano Claus from Curitiba has shown that fixing the mesh do not interfere if the mesh is going to move or not move. If you deflate slowly in the TEP technique and you makes fixation totally unnecessary. We have not fixing mesh in the last 10 years, but what we have doing is always we close the defect, because if you close the defect, the mesh has no way to go. So I believe that in the future, people will pay much more attention in closing the defect, the hernia defect, than in fixing the mesh itself. I guess it's just my point of view, but I would like to stress that.
I think those are very good, valid points. So the session 1 ends, and we are probably 6 minutes of lag, which we will cover up in the session 2. Over to you, Tarun, for the second part.
We are privileged to have a Japanese surgeon, Dr. Hiroshi. He's a senior head surgeon from Taikawa Hospital, Japan, and he would be talking about needleoscopic TAPP, and Dr. Danny Rausen would be his panel expert. Over to you, Dr. Hiroshi.
Thank you for giving me a chance to present my data in this program. Start my video. Yes, I want to share my procedure, how to pull out the hernia sac of sliding typing in a hernia with needlescopic devices. Hernia sac can easily pull into abdominal cavity in this case. In Japan, we call this type of inguinal hernia as de novo type inguinal hernia, cutting the peritoneum at the upper part of the hernia defect. To recognize the running course of spermatic vessels, start the procedure from the lateral side of the sac. This fatty tissue contains the spermatic vessels. And pull the hernia sac and properly apply proper tension and watch the difference of the color and what's the difference of fatty tissue and what the difference running course of the vessels is important. There is always a difference of the color, and we can recognize the difference of running course of the small vessels. And when fire the monopolar device at the appropriate point, the tissue is cut automatically and separated. If bleeding occurred, I will be misunderstanding the dissected plane. This procedure should be no bleeding. You can see the hernia sac here along the sac firing the monopolar momentary, not so long term, momentary firing. The tissue is reduced and there is no electrical injury to the nervous system. You can see the running course of the small vessels and gradually the hernia sac was appeared. And you can see the difference of the colors and the differences of the running course of the small vessels. Gradually, the hernia sac was appeared, and around the hernia sac, firing the monopolar device. You can see the dissected line in this video. You can see the hernia sac, and you can see the small running course of the small vessels along the vessels of firing the monopolar device. And this is the resected hernia sac. And next, this space is a pre-vesical space. In this space, it is important to understand the belonging or home of the fatty tissue. This fat is parietal fat or basal side. To estimate it, it is important. And here is always clear demarcation boundary of fatty tissue and can easily divided by monopolar cutting mode. The mesh is Basatex sizes 15 and 10 centimeter and fixed with absorbable tacker. Thank you very much.
Very nice technique. I just wonder, why do you call it needleroscopic? The instruments look, maybe they are 3 millimeters, or why do you call it needleroscopic if it looks like regular instruments?
This instrument is 5 millimeter port, 5 millimeter forceps, and I always use 5 millimeter or 3 millimeter forceps. And laparoscope is 5 millimeter flexible scope. I don't use 10 millimeter scope. I always use 5 millimeter devices.
And how do you insert the mesh through the 5 millimeter?
Mesh. This flat Basatex mesh can easily pour into the abdominal cavity by using 3 millimeter forceps through 5 millimeter port, or we pour into the mesh from outside into the abdominal cavity by 5 millimeter port.
Dr. Hirukawa,
yes.
I'm Dr. Rakis from Nepal. Very nice video. So,
thank you.
Is it IPOM for the composite mesh you use in this defect, or a simple polypropylene mesh?
IPOM.
What mesh have you used in this case? Is it a Paritex or it's a polypropylene mesh?
This mesh is Basatex mesh, Mediterranean Basatex polyethylene mesh. This is slight hard and easily easily to use in the abdominal cavity.
Okay, fine. Dr. Danny, any other questions?
Yeah, when I do a TIPP, I usually start a little higher because I saw that you went on the edge of the defect and then you have to raise a superior flap. And it might limit the upper part. You said that you use a 10 by 15. Sometimes, especially for these large defects that you showed, we may need a little wider mesh, 12, 13, even 15 by 15. So I usually like to start a little higher, then I have a nice flap below, and also the closure is much easier. But very nice technique. Thank you very much.
Thank you very much.
Okay.
So
Thank
now
you,
we move to our next
Hirukawa.
speaker.
Okay.
Next speaker. Thank you, Dr. Hiroshi. Thank you.
Thank you very
and
much.
Now,
may I ask a small question, sir?
Yeah. Yes, sir.
I have seen you have not closed a quite large defect, and besides that, you have used a very low weight mesh as well, because it's a very low weight polyethylene mesh that it's possible to pass by a 5 millimeter trocar. Usually, heavyweight mesh you need 10 millimeter trocar to pass through. Do you think that this patient may feel the mesh because you have not closed the defect, or you don't think it's a problem?
I always close it. I close the defect.
I have not seen the closure. Sorry.
Yeah, we didn't see the closure of the hernia defect. So, do you close the defect in all cases?
Yeah, no, I don't close the defect. But the direct type inguinal hernia, I always close the defect. But the indirect type, I don't always close the defect because I worry about the nerve injury.
Yes, that's a point.
Thank you.
I think very few surgeons are closing inguinal hernia defects.
Yes, agree.
Do you have any limit for closing or not closing? We have decided in our institute that every defect that is bigger than 2 centimeters in any direction in diameter should be closed. Otherwise, you can have first a very bad effect for the patient. The patient can feel the mesh when he just touch the skin. And the other problem is you have a higher index of recurrence. Do you have this kind of a number, a magic number, or you just look at the defect and you think it's too big, you just close it?
Okay.
In Japan, many surgeons did not cross the indirect type hernia defect. But in these days, some Japanese surgeons perform LPEC repair for the adult inguinal hernia. LPEC, it will be on a child hernia procedure for the child hernia. Some Japanese surgeons adapted the LPEC procedure for the adult patient.
I think,
and some patient will be effective without mesh some closure of the defect.
Thank you, sir.
Okay.
Thank you, sir.
Thank you, sir. Thank you. Thank you.
Next speaker,
Yes, sir.
Dr. Arun Prasad needs no introduction. He has been the past president of Obesity Society of India, and he will talk about the start of ETP. Dr. Arun Prasad and Dr. Danny Rosen is his panel expert. Sir, over to you, Dr. Arun Prasad.
Thank you, Tarun. Congratulations, Ramesh, Tarun, Jignesh, and all the organizers for such a wonderful topic. And it's a learning experience for all the faculty as much as it is for the delegates. So if you could start with my video. So standard starting of ETEP involves using of a balloon trocar or a disposable 12 mm trocar. Here I will show a technique where we are avoiding the extra cost of any of these disposables. So we would not be using a balloon trocar, nor would be using an opti-port for this procedure. After marking the port sites, we would then go on to make an indigenous dissector. So we generally mark the ports slightly lateral, and the remaining ports, even though we mark here, the actual port would be quite different. So here we can see 2 glove fingers have been cut and put inside, and the tip of the suction cannula should reach the end of the glove finger so that it does not hang down. And that is some saline being injected. So 50 ml of saline injected inside. That makes it 100 ml of saline. And this makes it 150 ml of saline. So it's good to test this out before is able to sustain. At the end of this, we empty the balloon, and now what you can see is that the incision is being marked. With the finger, you go inside, clear the anterior sheath, give a small nick on the anterior sheath, put in our suction cannula with the balloon behind the rectus muscle. So this is a bit of a blind procedure, similar to what my friend Kayur earlier showed. And after this, we inject 150 ml of saline and leave it for about 5 minutes to achieve some space and also to achieve hemostasis. So once the space has been created, then we would be emptying the balloon out, taking the suction cannula and the balloon out, and put in a standard 10 mm trocar, through which we will put in the telescope to proceed with the dissection. Most of the times you are able to see a nice field, very similar to what you would have seen otherwise with a balloon trocar, or if you had done a direct vision opti-port dissection. So that's the central space which has been created. And you can see we have gone down right to the left lower space. There is enough space laterally as well to put in the additional ports. So one lateral additional port and one inferior additional port has been put. So basically, to sum up, I would like to say that this is an indigenous method of placement of trocars in ETEP, whereby one can avoid the balloon trocar and also an optical port. Thank you very much.
Very nice demonstration. I always learn something new from Arun. And now I understand that by saving on optical trocars and balloons, where you have the money for the robots. Very nice.
Just a quick question from Dr. Arun. Do you mark the linear semilinearis with the ultrasound preoperative on the table, or you just draw a line on the patient?
No, in this particular patient, we did not mark. So the line which you saw was, a rough line. It has actually no meaning. And what happens is after you have created the space and you move laterally to the white line, then one can, put in a needle, as Dr. Bhatia was earlier saying, use your GPS. So the map is not that good. It's the GPS which eventually works. And I've often seen that the lines fail. So I don't trust these lines. I put in my trocar, create the space, and then go according to what I see.
Thank you, sir.
Okay,
Yeah.
Arun, just a simple question, because
Sure.
before Dr. Yagnik showed that he used air for ballooning and you use water for ballooning. Which do you prefer?
Yeah, saline.
Yeah, saline. Right. So you prefer saline.
Actually, used air. So maybe next time I'll try and come back with the answer, but I have always used saline.
Okay. I think, it would probably give you the low risk of bursting the balloon or something, maybe.
I think you can control the volume much better if you use fluid than you use
fluid, right?
gas.
Right. If you use air, then control is less. Yeah, that's good. That's a good presentation. Thank you, Arun.
Very good, valid points. Yes,
Thank you. So now we'll start with the next presentation. That is a mesh introduction in IPOM. Dr. Sadashiv Chaudhary, he's a surgeon from Mumbai, and he's a assistant professor in KEM Mumbai. And our panel expert is Dr. Gustavo. Over to you, Dr. Sadashiv.
Yeah, thank you. Also, I would like to thank HSI and Dr. Jinesh Gandhi and Dr. Anmol for providing this opportunity. Can you please play the video? Yeah, thank you. Today, I am going to talk about the IPOM and how to easily insert a mesh in an IPOM surgery. I'm Dr. Sadashiv Chaudhary from Department of Surgery, KEM Hospital. Generally in IPOM, the meshes which we use are the composite meshes. And these composite meshes are always bulky and difficult to handle. While putting these meshes, peritoneal surface should not, or the protective layer should not get damaged. Otherwise, it defeats the purpose of putting the composite mesh. Many people find it difficult to put the mesh, so that they try to put it through the skin. And that is very wrong. So I will show you here how to roll a mesh on a piece of a paper. So if you roll the mesh along its long axis, then it forms a long, slender, thin roll, which is easy to insert through your 12 mm port. Now I will show you the same thing on a composite mesh. So while rolling a composite mesh, mark your area. Along its longitudinal axis, you hold it with the needle holder, lock the needle holder, and along the needle holder, along the longitudinal axis, keep the protective layer inside and then roll it with your left hand as well as while right hand rotating the needle holder. Then don't leave this from your left hand. Hold it as it is and then take the same roll to your trocar. Many people try to just push it through the trocar and it doesn't go. So here is the trick. When you are putting that through the trocar, watch the movement at my wrist. So you have to rotate it and then put it. So automatically it gets rolled into a small pack and gets inside. And by this method, we can put even large sizes meshes very easily through the 12 mm port, and there is no need to convert it to the 15 mm ports. Again, another important aspect in IPOM is the transfixation of the mesh, transfixation sutures. So your angle of the suture passes decides whether your mesh is going to be exactly in the center or not. So in your pre-decided or pre-marked area, your suture passer should enter exact in the perpendicular fashion. Otherwise, it tends to pull or push the mesh away or towards the defect, so that there will be no adequate overlap from all the sides. So in conclusion, I will like to say, mesh insertion is the key to success of IPOM. Composite mesh needs to be handled with care to prevent the damage to the peritoneal surface, and correct angulation of transfacial sutures is recommended. Thank you.
Dr. Gustavo.
First of all, I would like to congratulate on the amazing video. I really enjoyed the way you rolled and inserted the mesh. I just got a little bit curious how to unfold and make the mesh plain again inside.
Yeah.
Because putting the mesh inside is also tricky, but unrolling the mesh and making it very plain is also very tricky sometimes. And the way you put inside is the key point to unroll it successfully. So I really enjoyed this way because most possibly not damaging the very kind surface of the mesh that would be in touch with the intestine and with the liver and with other organs. But I was really curious to see you unfolding and unrolling the mesh.
Okay.
The way we put is we just go it from both sides and to the middle, and we have actually 2 rolls, and it's quite easy to unfold in the end. And I don't know if it's quite easy to unfold this mesh this way, but anyway, I really enjoyed your way. It's very, very interesting, and I think everybody have learned something new today.
Yeah, thank you. I think I have learned this technique from my mentor, Dr. Jignesh Gandhi. I can tell you, okay, this unrolling of this mesh is very easy, because first of all, I have folded it made it in a halfway so that protective layers are facing each other. And we have a transfacial sutures which are already fixed to the mesh. So holding one of these transfacial sutures, you just stretch it and it opens up.
One of the things I found that many of these meshes, even though they look hard and stiff, if you moist them, they become much softer, much easier to insert. And also the one that you use, I think it's a ventralitis tip from Bod. It looks like that. Also, if you moist it, it goes very easily in. So it's a very nice technique, but most of them can be made easier by just moistening.
The only problem, what I've seen, Danny, with moistening is the peritoneal surface tends to peel off, when we're handling the mesh. That's what I have seen sometimes. And I prefer that the mesh gets wet, preferably by the peritoneal fluid itself. So I think that's a wonderful comment and a great video by Dr. Sadashiv. Can you go to the next one, Tarun?
Yeah, yes, sir. So, our next technique is a Manish technique in TEP repair. Dr. Manish Gupta is a colleague of in our department in Sir Gangaram Hospital, and he has devised a technique of 5554 technique. And the panel expert is Dr. Naeem. Over to you, Manish. You can take.
Thank you, HSI. Thank you, Dr. Jignesh, Dr. Tarun, and Dr. Anmol for giving me the opportunity to present this technique. I do hernia repair with all 35mm ports. Please play the video. Yeah. So this is my technique in which I make all 35mm port. And for this, I devised a retractor, which is known as Manish retractor. I'll tell you how I use it. So initially I used to make with the 2 ml syringe, but now I have made this retractor with an alloy, and I have a set of 3 retractors, and it's a cylindrical retractor with 2 blades, and they open at a degree of 90 degree, and they snugly fit over a 5mm trocar, and you can take it out whenever you want to. So I make a 5mm infraumbilical incision, and after making an incision, I put this retractor and suck out the extra fat. And what does this retractor does? Basically, it retracts the fat outwards and gives you a very clear vision of anterior rectus sheath. With a 11 number blade, you can precisely incise the anterior rectus sheath, And here you can see the rectus muscle fibers. And then I put this Visiport mounted over a 5mm telescope through this retractor, so that I go precisely in between the anterior and the posterior rectus sheath without injuring the posterior rectus sheath. This is the cranial and the caudal lip of the anterior rectus sheath, which I incise, and then with the Visiport I go inside. So I'm using this technique since October 2014 and published my work in 2016. And I filed a patent for this retractor also. So once you reach in the preperitoneal space, you just take out the retractor without taking out the trocar. So the two blades help in this procedure. You just open the retractor without taking out the trocar and leaving the trocar inside the body. So that's it. So after this, I make two working ports. I make working ports on the lateral side, though it's not the part of this technique. I was trained in doing with the lateral ports. So after dissecting, I also devised a technique to put a adequate size mesh through a 5mm port. So this is a 15 into 15 centimeter size medium weight mesh. This is rolling soft mesh. So after this, I put after rolling it, I put a thread at one of its end and make a tail of 20 centimeter, and then I pull this tail inside. I'll tell you how I put this tail inside. So a 15 into 12 centimeter mesh can easily go. Here I am using a 15 to 12 centimeter of medium weight mesh. Even a 15 into 10 centimeter of heavyweight mesh can be introduced, but with some little difficulty. So I first introduce the thread inside, leaving the thread in the preperitoneal space, and then I go through the other working port, and then hold the thread and then pull this mesh inside. You can see how 15 into 12 centimeter mesh, this is a medium weight mesh, and you can very easily pull this mesh inside. So after pulling the mesh inside, you just unroll it and it completes the procedure. You can fix it wherever you want. And at the completion of the procedure, there is no need to put a suture on the anterior rectus sheath because it's only 5mm. You don't have to close the fat. There is no induration. Patient is happy. They have a very smaller incision. Especially females, they don't have a scar. So this is the final picture. So all the advantages of 5mm ports, along with there's no dependence on the Hudson trocar, and cosmetically patients are very happy. So I did since October 2014, and 271 consecutive hernia repairs has been done, out of which 3 are femoral. And so this technique is easier, safer, reproducible, and less morbid for TEP repair of inguinal hernia. And the practice that it follows all the principle of TEP repair. Thank you.
Thank you, Gupta. That was a wonderful demonstration of your invention. And actually, it is really very appreciated that you have kept all the 3 talkers 5mm, and you have done it very nicely. But actually, I want to know what is the length of this retractor? What you have made?
Sir, I have a set of 3 retractors. One is 2.5 centimeter size, the another one is 3.5, and the third one is 4.5 centimeter size. Even I have also asked for a 10mm retractor, which carries a 10mm trocar and can be used in ETAP also. So I have now 4 retractors. 3 are of 5mm diameter and 1 is of 10mm diameter. So depending upon the thickness of the subcutaneous fat, I use these retractors.
Okay, fantastic. So I thought for 10mm, do you need this kind of retractor? Because for 10mm, you can use a long right angle retractor, conventional retractor. But for 5mm, I think this is a very good one. I mean, you can avoid extra incision for 5mm, you know. And actually, this is a great thing. And I really loved your way of pulling the tail of your mesh introduction, and it is great, because when you pull the mesh from inside, well, that should go well. And I think you don't have any problem putting a mesh through 5mm. What Gustav was telling before, that for putting mesh through 5mm is quite difficult, but we have learned something new, that if we pull it from inside, it should work. Thank you for your any comment?
Yeah, I would like to comment, Dr. Tarun. In this, you would have to use a lightweight or a medium weight mesh. You cannot use a normal proline with this technique. So Manish does it with lightweight or medium weight?
No, Tarun, I started with putting heavyweight mesh, and I used to put surgery pro mesh of 15 into 10 centimeter size in my initial cases. But it was little difficult to put in because it has got some memory, but it's not impossible to put up 15 to 10 centimeter size. Yes, definitely 15 to 12 centimeter size of heavyweight mesh is difficult to put inside. But with medium weight meshes, it's very easy to put these meshes.
Lightweight and medium weight should work.
Yes.
Yeah.
I have a little
Wonderful.
question.
Yes, sir.
Danny.
I have a little question. Very nice video. I just didn't understand, if you use an optical 5mm trocar, why do you need this extra trocar to put the fat out? Because with the optical trocar, you just go through it and reach the fascia without any problem.
Yeah, that can be done, but one has to be precise to put the trocar in between the anterior and the posterior rectus sheath. So I devised this detector so that you can precisely make an incision in the anterior rectus sheath, and you don't go accidentally into the peritoneum, injuring the posterior rectus sheath. So this detector helps in this point. You can go directly into the in between the anterior and the posterior rectus sheath without this retractor. That's not a problem. But sometimes you put some accidental force and you can go inside. So one has to be safe.
Especially for the beginner, maybe it will be more helpful.
Sir, it's very easy to put this through this retractor. It hardly takes 2 minutes of your operating time. While putting a Hassan trocar will take approximately 10 to 12 minutes of your operating time.
Thank you, Manish. Thank you. I think we're short of time.
Thank you, Manish. Yeah.
Thank you.
And that is our Pinak stitch mesh fixation by Dr. Pinak Das. He always uses this P as a Dr. Pinak from Chennai.
Thank you. Thank you for my second turn. This is P-stitch, and this is basically extraperitoneal mesh fixation stitch. So it's not that I use it always, but when I'm using a barbed suture, I prefer to put this stitch for mesh fixation. Can we start the video? So one important thing to note is it is only for extraperitoneal placement. So what you do is a simple suture. So you have placed your mesh and you put 2 throws of your V-lock suture through the coopers and then bring the needle through the loop so that it gets locked. It is for them who find it difficult to put a knot in a confined space like TP, or for that matter, any confined space. So this suture is good enough, it stays and it is pulled and seen that it is staying in that place. So similarly, the other coopers is also fixed. So mostly when I'm plicating a direct sac, I'm left with some amount of V-lock sutures. So I use this technique to just fix it. Suppose I put few knots, I lose some length of the sutures also. So this way you can save some length of the suture so that you can place adequate amount of fixation. It's not too tight, crush a nerve or something, and it keeps your mesh in place. If it can be adjusted so that the length of the tail on either side is no more than 2 centimeters. And you don't have the hassle of putting knots and all. Thank you.
Thank you, Dr. Pinak. Dr. Rakesh Gupta, sir, your comment and any.
Yeah, thank you, Dr. Pinok, for very nice way of fixing the mesh. Actually, the country like us, where we lack mostly the tag, glue, so most of the time even we also use suture in our TP hernia repair. So especially when we do the unilateral TP, when all ports are in the midline. So for the beginners, sometimes it's difficult to tie a knot. So maybe this technique will be the better if you are doing TP, especially in all the port in the midline, and difficulty in for the beginners, difficulty in tying the knots. So very, very nice technique.
One more thing is that many of the people are using tacker, but we know that For it's only a matter of one or two tack for bilateral fixation, and then we have to re-sterilize, which is not a good idea. So if we are using, for me, I can suture. Normally, I don't use, but for someone who has difficulty in doing in a narrow space, this is a good idea. And whenever I've done with my plication of a pseudo sac, then whatever the stitch is left, I use this technique to fix my mesh.
Thank you, Dr. Pinat.
Thank you, Dr. Pinat. Thank you.
I think when we talk about Jugad, I think this is exactly these kind of things that we want to see. Very nice, very nice.
Thank you, thank you.
Thanks, Danny. Can we go to the next video, Tarun? That's your video?
Yes, sir. So,
yes. So we again come back to Tarun. Yes, Tarun, go ahead.
With narrow neck ventral hernias with lot of omentum in obese patient, sometimes there is a lot of difficulty in omental reduction and there is bleeding intraoperatively, and sometimes these bleed post-operatively also. So to reduce this bleeding, we have devised this technique and we have used in few of our patients, and for us it has given us good results. Anmol, can you play the video? So after doing a diagnostic laparoscopy and when we are doing reduction of omentum, we just divide the edges of the hernia with the help of scissor or any energy source also we can use. And after that, when we're trying to reduce, we just give 1 or 2 push, and from above also we give some push. And if we are having a difficulty in reducing these contents, instead of opening the size of the neck and increase the size of the hernia, what we do in obese patients who have a lot of momentum as a reserve, we just use a energy source like a harmonic or a ligashore and divide this momentum. And easily then we take this off. Now we can do a lot of traction in this because now we have divided it. We are not worried about the bleeding. And then we can just keep it in the endo bag and remove it. We have to be careful in patients who have less momentum. Generally, we are using the third generation mesh. So generally, the chances of adhesions are less in these. So we can use this reduction of momentum using this harmonic and then use a third generation. I understand that there's a momentum cover might reduce in some patients. So in that, we try not to do this. Thank you.
Ramesh, da?
Yeah, excellent.
Ramesh?
Yes, it's very innovative, Tarun, very innovative.
So, yeah, so Tarun, that's a very good idea. And, fortunately, what happens is we keep on doing the same work in different places or different continents. And so I like that technique. What I also tell people is, always try to pull the momentum from the sides after cutting that small rim of fibrosis there. And I give them the concept of the local trains in Mumbai. If you want to get in and out of the local train, you always get up from the sides. From the center, it's extremely difficult. The second thing is that for the postgraduates who are watching on the Docplexus, always remember that omental does not have any natural striated muscle fibers. So bleeding in the omentum should always be controlled there and there itself, because once you have reduced the omentum down, you will be landing up in a pool of blood. And then it's very difficult, I can tell you with experience of all these guys, to find out where the bleeding is from. So remember, do not take the omental lightly, because in some patients, you can have large vessels which can bleed torrentially. So I think that was a great session. And I think we end the session 2 here. Anmol, can we move to the session 3? We are slightly delayed by about 10 to 12 minutes, but I think we've got some wonderful discussion generating up here. And that's helping the audience. Please put up your questions to the presenter if you have individually, which can answer at the end. But I think we've got good kickstart, good inputs coming from Danny, Dr. Gupta, Dr. Naeem, and the presenters are doing a wonderful job. So we go to the session 3. So we have finished around 11 videos now, and it looks very interesting as we are moving through. Yes, Tarun, let's start.
Yes, sir. So now we start with the next session. It's an icon tactile trick by Dr. Mandar Gadgil from Mumbai. He has his own Gadgil clinic. So over to you, Dr. Mandar.
Thank you, Dr. Tarun. Good evening, everyone, and thank you, HSI, for the wonderful opportunity. So coming back, IPOM probably is one of the first surgeries that is done after you have mastered your basic appendectomy and cholecystectomy. But the major third block in Anmol, can you please run my video in the background? Yeah. So the major thought block in an IPOM is what if I injure the inferior epigastric pedicle? Because more often than not, the preperitoneal space is studded with variable amount of fats, which makes the inferior epigastric artery slightly invisible when you're looking it from inside. So this is a 48 years old female who had a 3 centimeter primary umbilical hernia. The routine steps of an IPOM were followed. The contents were reduced. The falciform ligament was taken down. The defect was eventually closed with a barbed suture. As you can see, this lady has got a significant amount of preperitoneal fat. Although the inferior epigastric artery is nicely visible in this patient, but just this was a good case to demonstrate. So what we have started doing is we bring the overhead OT lamp really down as close to the abdomen as possible. And if you have a good intensity of the lamp, just watch my hand. I'm taking off the light supply cable from the telescope. What it does is it illuminates the abdomen from outside. It's a readout on the abdominal wall once you switch off the light cable. So having followed this, once we are close to tacking, once the transfacial sutures have been taken in place, once you are close to the lower pedicle, you switch off the cable lamp, and this is where you see the inferior epigastric artery pedicle seen closer to your tacker, and so that you can note it. And what I do now is called the castling technique. I fire one tacker on either side under transillumination vision, so that I don't fire on the artery even if I'm not in vision of that. So I do it on the right side. I fire intermittently, moving slowly to the left side. The light on top moves in sync with my tacker. The OT assistant keeps focusing it. The inferior epigastric artery pedicle also is on the left side, also is well visualized. I take off my hand, the pedicle is seen, and then I go on every 2.5 to 3 centimeters for the outer crowning. There are numerous methods described on how to tackle if a bleed occurs. I didn't find too much of literature on how to prevent the bleed in the first place. But there are a few people who would, using ultrasound guidance, mark it on the surface prior to surgery. Or sometimes people switch off the OT light from outside and using the telescopic light, mark the artery from outside on the skin. But that is a fair estimate, not a very accurate estimate, because it is not in real time. Here, this technique will help you to identify the vascular pedicle in real time, so that the chances of injury go down really, really now. So once you finish the outer crowning, another advantage of this technique is we talked of the suture defect. So you can see the suture defect very nicely transilluminated against. So the inner crowning also becomes very easy. We'll see that in a minute. So this is the suture defect seen against the transillumination. So the inner crowning layer also can be centered accordingly. That's an additional advantage, not the main intent of this technique. So, and since you're working on the roof, entrapment of any structure is virtually not possible. So at an appropriate time, you switch on the light, you confirm that the double crowning is achieved, and this is the final look without an injury. Thank you for your time.
Thank you. Over to you, sir. Dr. Danny.
Yeah, very nice. And I think that's one of the proof that despite all the talks about ETAP and TAR, IPOM is here to stay for quite a long time, and we really need all these little tricks. And one more comment, because of the COVID, we are not going to travel abroad anymore. So we just, it made me remember the red light district, but it's very nice.
Can I make a small comment, sir?
That's a good comment. Yeah.
And Dr. Mandar, are you using these absorbable tackers, or have you shifted now? There is literature available.
Yeah, so currently they have shifted on to the coated non-absorbable metallic tackers. But this is about a 3 years old video where probably that was not so popular. So this is the absorbable tacker used.
Now it is, it increases the chances of recurrence. It is, a lot of papers are available now.
Yes, I agree.
Advantage in pain also.
Totally agree.
Yeah.
So Dr. Mandar, do you use the same technique when you use the suture passer for ligature?
suture passer also, yes, I have not tried it. It's a good suggestion though, but suture passer probably you are anyway going to entrap the vessel in case you injure it. So I have not tried it in a suture passer while taking the transfacials, but yeah, it's a good suggestion. I will try and incorporate it in the next case.
Yeah, I think we can also try for that. Yeah.
Thank you, Dr. Madhan.
Nice.
Thank you.
May I do a comment?
Yes, yes, please.
Yes. First of all, I would like to congratulate. Very nice idea. Every time you are preventing a problem, it's an amazing idea. This is a great sugar. The other thing that I'm quite surprised that even though we hear everywhere that iPhone is dead, I see iPhone everywhere. And I still believe that iPhone will stay among us for a long time because it's quite straightforward technique. You don't need to dissect too much the peritoneum or any other layer. And you just need a good mesh to make your iPhone. And in the case of the big umbilical hernias, one thing that is quite mandatory here in Brazil, especially for younger women and people who are caring about the cosmesis of the umbu, is you need to do omphaloplasty in the skin. So you make a nice umbu in the end. So why you need to use barber suture if you are going to open the skin to do the plasty, the umboplasty? So we are always throwing the mesh inside from the opening of the skin in the umbo. And if we are going to do a IPOM for a recurrent umbo hernia, we already have the mesh inside from the opening, and we close in a just regular open fascia, and we do the omphaloplasty, and in the end we finalize it by our IPOM. And it's quite easy to place the troca inside because you can do your technique from very high, close to the ribs, to place the 10 millimeter or 5 millimeter scope. And when it's very inflated, it's quite interesting that you don't need to close it in the end because the facial hole will be over the ribs in the end. So it's a kind of tricks for big umbo hernias. If you still want to use iPhone or not using the robots for doing very fancy techniques.
Thank you, Dr. Gustavo. And I can say that the success of our meeting today is I could, see that Danny and you have got a perfect pronunciation of the word jugaad, and that itself says that we are going great. So let's move to the next video.
Yeah. So now next video is cigarette unrolling approach to mesh deployment in ETPRS approach. Dr. M.A. Banker from KM Hospital, Mumbai, and Dr. Gustavo sir will be the panel expert.
Amay, please unmute yourself, Amay. We can't hear you.
Hello, can you hear me now, sir?
Yes, go ahead.
Yeah, I'm a resident at Straight GS Medical College and KM Hospital, and I've worked on this approach under the guidance of Dr. Jignesh Gandhi. So can you please play my video? So here I'm presenting an approach for an effortless deployment of a mesh in the ETEP Reeves Topa repair, which was done for a 50-year-old gentleman with a 5 by 4 centimeter partially reducible umbilical hernia. The ports are placed as shown in the figure. Now, the retromuscular plane is created using the standard technique, and the place is then measured for accurately cut the mesh. Here we'll now demonstrate the anisotropy of the mesh, that is, the variable in the flexibility of the mesh in different directions. We advocate placing the flexible part of the mesh in the craniocaudal direction so that for more flexibility of the mesh during flexion and extension movements. We take a vicryl stitch and the mesh is rolled over the vicryl stitch as shown in the figure. A second vicryl stitch is used to fix the mesh, and the mesh is then introduced via the 10 or the 5 millimeter port. Now, once the mesh is introduced, we can see how rolling it onto a vicryl suture helps us for an effortless deployment of the mesh. One end of the mesh is held by a forceps, and by just tugging on the vicryl suture, the mesh is unrolled into place seamlessly and effortlessly. Packing or fixation of the mesh is optional. We can use either absorbable tags or glues. And we first go for an desufflation and re-insufflation test to look for the patency of the fixation of the mesh, and then all the ports are removed under vision. Thank you.
Yes, Dr. Gustavo.
I'd like to congratulate. This is a really, really great yoga because looks very, very easy to unroll the mesh. As I told you before, unrolling the mesh is even a worse problem than just inserting the mesh itself. And if you already have one suture, this is amazing. I have not thought about that before. I'm most possibly using in my next case. But one thing I do is I always put a long stitch in one of the border of the mesh. And because I'm really fond of transfacial fixation, I started fixing one of the border of the mesh before enrolling it. So it's already fixed at the very bottom part or the very higher part of the hernia. And after that, you unroll the mesh. But if you put two sutures in your mesh, maybe not a problem, especially if you use different colors. Maybe you put one suture of Vicryl, the other you put like Ethibond, and you have different colors, one for transfacial fixation, the other for unrolling the mesh. But anyway, I really want to congratulate you. It's an amazing video. Really enjoyed that.
Thank you. Thank you so much, sir. This was done under the guidance of Dr. Jignesh Gandhi, sir.
I think, for the audience, Amay, that was a wonderful presentation. It's very important for all of us to understand today the anisotropy of any mesh. Like rightly pointed out, that always have the flexible side in the craniocaudal dissection because our transverse core muscles are more stronger. So the importance of this video was to put the mesh, unrolling it, but always use the anisotropy to our benefit. A great video. I think we should move to the next Tarun. Thank you.
Thank you, sir. Thank you, sir. So now our next presenter is Dr. Sumanta De. He's from Calcutta. His video is pseudofax fixation in groin hernias. And Dr. Rakesh, expert panel. Dr. Sumanta, over to you.
Thank you everyone. Good evening. And I'm going to demonstrate a technical adjunctive procedure during my TEP procedure, mainly to reduce the seroma formation. So can I play the video? Yeah, right. So what I do is in my TEP procedure for direct hernias, I usually fix the pseudosac with suture fixation with the ipsilateral Cooper's ligament, and that significantly reduces postoperative seroma formation. So what I do is after completion of dissection, I pull the pseudosac with my left hand instrument, and with a 2-0 Prolene suture, I take 2 or 3 thick bites. And while taking these bites, I ask my assistant to put external compression otherwise the pseudosac will tend to go away from the operative area. So after taking those 2 or 3 bites, after orienting the needle properly in the needle holder, I take a 3 thick bite over the Cooper's ligament. And after taking this bite, when I place the knot, the pseudosac will automatically come and sit over the Cooper's ligament, and thus it will obliterate the dead space over that area, and thus it will prevent any clinically significant postoperative seroma formation. So while placing the stitch over the Cooper's ligament, you may have some minor bleed over that area, which can be easily controlled with monopolar cautery or bipolar cautery. So seroma formation in the postoperative period, mainly after TEP direct hernias, is an important area of concern, mainly for the patients, even if the patients are preoperatively explained about the nature of this event. But in case of large direct hernias in postoperative period, if there is a significantly large seroma, that sometimes may give a patient uneasiness or discomfort. So in literature, there are various adjunctive techniques already mentioned, like pseudosac fixation with Cooper's ligament with the tacker, and then there are other techniques like stapler division of the pseudosac, then glue fixation of the pseudosac. But why I implemented this technique in my practice is because this is a simple and easily reproducible technique. This is very cost effective if you compare with the other techniques of pseudosac fixation. And once one who is comfortable in suturing, this can be easily done. Even if the hernia size is bigger, like more than 3 centimeter, you can take 2 or 3 bites with the pseudosac and easily fix it with the ipsilateral Cooper's ligament. And I have done almost 59 cases of the direct hernias and applied this technique, and there is definitely less chance of seroma formation. So after completion of this technique, you can place the mesh nicely over that area and complete the procedure. So that completes my procedure, and thank you HSI and the organizing team for giving me the opportunity to demonstrate my innovative technique of post-operative seroma formation reduction. Thank you.
I have a small comment. It's very nicely done, and I think most of us agree already that direct hernia should be closed that way or another. And I think this is really equivalent to closure of the defect. I'm not sure about indirect, as we spoke before, but direct hernia, I think it's quite commonly done. My technique is usually, I use this technique for many years, and then I switch to something that looks, I think for me it's easier. I fix it anteriorly to the rectus muscle and not posteriorly to the bone or to the Cooper ligament. And I use the suture passer for that, and it takes half a minute just to pass the suture through the sac and back into the abdominal wall. But there are many ways to do it. I think it's quite important.
Dr. Rakesh Gupta, sir, you are the expert panelist. Would you like to comment, sir?
Yeah, thank you, Dr. Sumanta, for a very nice presentation. I mean, there are plenty of articles suggesting that we need to close the direct defect in any form, like you have showed the pulling the pseudosac and tacking with the Cooper's ligament. But we need to be very careful when we take the suture on the bone, because sometimes aberrant vessel running on the lower margin of the direct hernia. So that is one point. And another issue is coming, like integration of the mesh on this pseudosac. So what's your view regarding that?
So integration of the mesh over the pseudosac, see, even if you fix it with the adductor sheath, anyway it is going to come over the mesh area. So I don't find any difference in the post-operative outcome, because these patients are on regular follow-up. So I have not seen any kind of recurrence or any significant post-operative pain or discomfort in this kind of patients where I've applied this technique. So, and other point, like which I've mentioned, definitely there are some aberrant vessels over that near the Cooper's ligament. So we have to be very cautious while placing the stitch, and while that is a technical point. And even if there is small bleed, that can be torrential sometimes. So we have to be very cautious, right? You rightly said, sir.
Thank you.
Yeah, just a small comment about the cost effectiveness. Yes, Sumanta, I agree with you, because in this part of the world, we really need to think about the reduction of cost always. So rather using a tucker or other ways of fixing it, if you do it in this manner, it will really reduce the cost. Thank you for your beautiful presentation. Yeah.
Thank you.
So now
thank you. Let's move on next.
Yeah, our next speaker is Dr. Yusuf from Aligarh. The topic is management of complex ventral hernia, and Dr. Naeem is the expert panelist. Dr. Yusuf is assistant professor in GM Medical College, AMU Aligarh. Dr. Yusuf, over to you.
Yeah, thank you, Dr. Tarun. And this is the case. It is actually improvisation in a patient, and a young female of 25 years of age came with a hernia in this incision, and this incision was given when she was a pediatric patient. In early childhood, she went some laparotomy for some perforation, and this very ugly scar, and it was around 8-9 centimeter defect on one corner on the right side, and she was also having multiple Swiss cheese defect, and it was L2W2 hernia, and 16 years back she has perforation. The problem with her was that she was not affording the consumables of IPOM. So laparoscopy was not affordable to this patient. And I didn't want to give a vertical midline scar in this patient and make a plus-like scar and very uncosmetic. So went through the same scar, to the same incision, and then I did the pre-peritoneal repair, and in this technique, I could get the wide mesh overlap, just like a tar, without doing tar, up to the diaphragm, up to the pelvis, up to laterally, up to the psoas. And in some part, the peritoneal got torn. So just like tar, I bridge it with the momentum. I use the momentum of this patient and bridge that peritoneal defect. And without creating any another scar, the hernia was repaired in this patient who could not have afford laparoscopy.
Okay.
Okay. Thank you.
Yes. Yeah, that's great because you have tried your best. I mean, you have tried to give the patient is only 25 years old, having such a bad and complex metal hernia. But I really liked your approach because the patient couldn't afford laparoscopy and all other consumables. So it was a good try. And when did you do the surgery? And actually, can you give us some update about the follow-up of this patient?
Yeah, she has a very nice follow-up without any problem. And since this was not attempted in many centers, after multiple centers, she came to us. So she was very satisfied with the surgery and no surgical site infection, no seroma, and around 1.5 years has down, and she has no recurrence also. And she was quite happy.
Okay. Okay, that's great. I congratulate you. And in this part of the world, we need to do things like this.
And I could get the same plane, the wide overlap. I was not expecting such a wide overlap. And since we are doing tar, so there also we have tear in the peritoneum. So here also I had, and just like tar, I bridged it with the momentum. So the experience of tar came in this patient.
Thanks, Dr. Nalman.
Thank you.
Thank you. We will move to the next presenter, Dr. Sanjay Devadhar. His topic is prevention of recurrence, mesh buttons. He's a senior surgeon in Pimpri, Pune. And Dr. Ramesh and Dr. Jignesh would be the expert panelists. Over to you, Dr. Sanjay.
Thank you very much. Am I audible?
Yes, sir.
Fine. Basically, I'm short eyes man. My video. Thank you. This is ventral hernia prevention of recurrence. As usual, this is a parambilical hernia. I always reflect the skin, then routine herniatomy. EP space is created. Normally, I do a gauze dissection. The EP space is created properly. Then I open the sac. It was adherent omentocele. Reduce the momentum in the peritoneal cavity. And then closure. Herniatomy is completed. This is the wide gap. Now, this is prevention of recurrence with mesh buttons. Roll it twice. Applying 8 hemostats. Cut the strip. And create the buttons. Simple procedure. This is all my innovation. The mesh is cut to the size required. I place the mesh in the EP space sublay. First, stitch through the button, then through the sheet, come inside, take a bite of the mesh, come outside, come through the button, and then tie over the button. They are not very tight. So you necrosis of the tissue in between the mesh inside and the button outside. This is a simple method I developed, putting all the 8 buttons diagonally opposite each other, and then a double layer closure of the sheath. And this is closed sheath, second layer. This is a simple method I developed to prevent the recurrence. And the recurrence is mainly because of sutures cut through, tissues give way, mesh migrates, and infection. Drain is placed, subacute holding stitches. I hardly excise the umbilicus. Prevention of recurrence is preparing the mesh buttons, fixing the mesh, inlay mesh is fixed, mesh button fixation relieves tension. Thank you.
Dr. Ramesh.
Yes, quite innovative. Quite innovative. Jignesh, over to you.
So, yeah, Dr. Sanjay, I have just 2 questions. One is the world is now slowly moving from heavyweight to medium weight to lightweight mesh. And here, we are looking at additional mesh used as buttons. So your comments on that. And second, God forbid, if this patient develops an infection and a sinus, how are you going to be sure that it is coming from which of the 8 buttons which are on the only area? Because these are little testing times that if you have an infection, whether you're going to remove all the buttons, and have you have any such experience in the past? Thank you.
The weight of the mesh is going down day by day, but the weight of the patient is increasing day by day. The problem is with the obese patients, the area where I'm practicing, I come across such patients 100 kg plus, 90 kg plus, and in those patients, and I'm exclusively practicing open surgery, let me put it bluntly. So those heavyweight patients, with my experience in the past, experience of the colleagues, I developed this method to put the mesh buttons for fixation. First, I presented my paper with 50 cases with good result. And now it is 350 plus cases which I have operated with this method. I proudly say I didn't have infection in single case up till now. Follow-up available. It is your technique and tissue respect you can create this particular result.
Okay.
The mesh never migrates.
Something.
Pardon?
Yes, go ahead. You're saying something.
The mesh never migrates. See, before the mesh was being put on, the sutures used to cut through. I started this when I observed suture site hernias. You must be knowing you put an onlay mesh and fix it at various places or maybe with a continuous suture. At those places, the sutures used to cut through and small tiny holes giving rise to those suture site hernias.
I agree with you, Dr. Sanjay, because that's where now the concept even in ICOM has come, that you can have a hernia at the site of the transfacial sutures.
Yes.
So since this is something different, I would like to have one quick comment from each of the expert panelists, starting with Danny. Yes, Danny.
I think we are back to what Gustavo said in the beginning about fixating tap mesh, and this is quite similar. You're dividing such a nice peritoneal space. You have a large mesh. In these cases, I don't really fix anything. I just close the defect around it, above it, and that's it. The mesh will just stay there. So you don't need not the regular sutures and not the buttonhole.
Okay. Dr. Gustavo, one quick comment.
I fully agree with Danny. You already had a very nice space. You have already had put the mesh. Just closing the defect over the mesh would be enough. The mesh had nowhere to go. And in the end, you would have the same effect of a lap tap with open surgery. You just need to do a very nice umbu plasticine, that's all.
Okay, Dr. Rakesh?
I think it's just like a ventralite ST patch we are putting, and my only query is just like Dr. Jignesh, the putting of 8 pieces of mesh at the suture line. That's it. Thank you.
Dr. Sardar, Dr. Naeem, sir?
That's great that Sanjay has experienced more than 350 cases without a single case of infection. And that is really, really appreciated. And of course, what Jignesh told, that extra 8 pieces of mesh for button, whether it is necessary or not, but since he has got a great result, Sanjay, and I really congratulate him for his endeavor. And
Dr. There's a question from the panelists, these speakers. What suture are you using?
Duoproli.
So I would just sum up and say, Dr. Sanjay, that I always believe that along with evidence-based medicine, there is also something known as experience-based medicine. And you have rightly put it up with the volume of your cases. So we take it in all pride. Wonderful sharing your video. I think we come to the end of the session 3 here. Wonderful, it's going, and now we are in the last league of this. Thanks all of you for presentation so far. So we are now in the last league and some more interesting videos coming up. Tarun, let's start the last league now. Thank you.
So our next presenter is Dr. Vikas Singhal from Medicity Hospital, Gurgaon. His video is about TAR staying in the right plane, and Dr. Danny Rosen is his expert panelist. Over to you, Dr. Vikas.
Thank you. Brilliant HSI webinar, a lot of innovative things learned. My confession is that I don't have a jugaad, just what I picked up in my initial 10 cases, and I thought I could do better to cut down on the buttonholes I was making during doing the TAR. So just a couple of pointers I wanted to share. If you could please run the video.
Anmol?
So this is just to give you some perspective of the patient. Big hernia, loss of domain, reducing all the content where it really belongs, getting down to the edges of the hernia, starting our retrorectus dissection. So I like to mark everything as I go along. Doing the retrorectus dissection all the way to the linea seminonaris, completely from top to bottom. I like to complete every step before I move to the next one. And this is really what I wanted to show. So, people have often asked, what is the line of division of the posterior lamina? I mean, on the lamina of the internal oblique, where to do the TAR. So this really is a zigzag line. It's not a straight line, which, I visualize all the neurovascular bundles and I do my marking just medial to the neurovascular bundles. Because we know that there isn't a lot of space to do the TAR as we come down to the umbilicus and below. So another point, it's very important to have the right stretch from your assistant, and my left hand does the stretch, myself. I also save the viscera from the cautery by my own hand. So I find it really important to completely lyse the posterior the lamina of the internal oblique before getting tempted to start the TAR. It's very tempting to just pick up the muscle and divide it here now, but that's what I found I was doing initially, and then I was losing my plane. So once that is completely done, then you can lift up. You can see the transversus abdominis inserting just medial to this point of cautery. Important to have the right stretch, lift up the TA, and do the division of the TA. Now, as we go up towards the xiphoid, we find it's nicer, bulkier muscle, and there I realized that got a little bit more left of the posterior lamina as we go up towards the xiphoid. So we'll have to divide that before we can get down to the muscle. And that's the only way to divide the muscle, to be able to get under the rib cage. Another little point here, that the TA insertion is not like one fine point. You may have to use the cautery to further divide the TA until you are able to just slide it off the transversalis fascia. And once that is done, then we are just able to bluntly separate it and dissect it, without needing much cautery anymore, just bluntly in this bloodless plane, dissect it back off the transversalis fascia, and hopefully not have many buttonholes. Thank you for that.
Very nice demonstration. I think sometimes when the technique is so good, we don't need any tricks, just staying on the correct plane, and that's it. Very nicely done.
Thank you so much. Thanks.
Great, great. Shall we move to the next video, Tarun? Please, Pinak.
So next video is P-flap tension-free closure of posterior rectus sheath. Dr. Pinak and Dr. Gustavo is the expert panelist. Dr. Gustavo and Pinak. Pinak, over to you.
Yeah. Hello and thank you. This is the third time I'm here. So this is P-flap for tension-free posterior rectus sheath closure. Actually, this is not a situation which you will encounter very often. This is a rare case of hernia, which is a supraumbilical hernia with a large inguinoscrotal pantaloon hernia in a 70-year-old male. I can see how big is the hernia, and he also has a supraumbilical defect. So this is E-tap approach. So normal conventional E-tap done, crossover done, the supraumbilical hernia taken down, and now you go to the inguinal space. So this is reduction of the indirect sac. He was carrying this hernia for almost 8 years. So now you move to the indirect component is reduced. Now you move to the direct component. So once everything is mobilized, you actually have a huge peritoneal sac or peritoneal flap. So this is the inferior epigastric artery and the pantaloon defect. So this is parietalization almost complete. Now the pseudosac is, as usual, used to close the defect. And then again, you go up and close the supraumbilical defect with a non-absorbable locking suture. So after this thing, there was the defect in the PRS. So since there was a large peritoneal flap which was already present there, so I mobilized it up to close the posterior rectus sheath in a tension-free manner, without the need for any further release of the transversus abdominis or something like that. So I definitely understand that this is not a regular situation which one will encounter. But then if such kind arise, the peritoneal sac can definitely be used to used in a good way to close the PRS. In this case, he was a small man. Stature was small actually, so his retrorectus space was limited. So if this sac was not used, he would have definitely needed a unilateral component separation. So the rest is almost the same. The hernia is fixed with a large 18 into 14 centimeter mesh. And again, the retrorectus space also was filled, another mesh was used, 23 into 15. And the entire area was covered. And the Romovac, this was a little bit oozy case. So definitely we left behind a Romovac suction drain. Thank you. Thank you, HSI. Thank you, Tarun. Thank you, Jignesh sir. Thank you, Anmol, for giving me this opportunity for the third time. Thank you.
Thank you, Pinak. Dr. Gustavo, sir, over to you.
Yeah, I'm going straight. It's an amazing video. You had a problem that is huge, excessive sac, and you used the problem to fix the other problem. So you just did a very good job at it. It's amazing. I don't have much comments on this. I have never thought about that before. I have never used the sac for this.
Yeah, this was the first and the last time for me. I also have not encountered something similar like that. So it was the first time, and
this is a really great trip.
Info?
Sorry?
Really great trip, and I really congratulate you.
Thank you.
Now, we have a question from Dr. Naeem.
Can you give us some follow-up information? Yeah, just follow-up information. What was the result later on?
He is a farmer and he is doing good actually. He lives alone, so he has only comes once for the follow-up, and which was only some 14 days after the surgery. After that, he never came back. He's separated from his family and he stays alone. So probably that is the reason. But he came some 14 days later and he was doing fine. He was quite happy because he was carrying this for 8 long years.
Thank you. That's a very intelligent idea.
Another small comment.
Thank you.
Yes, Gustavo.
Yeah. Just another small comment about the drain. Drainage will be always a fight among surgeons.
This was
I
particularly
have never
easy.
used a drain this positioning.
Since it was a large sac and bit oozy, and the amount of dissection extending from supraumbilical till the groin, so I thought, and it was taken out the very next day. And it was taken out the very next day actually, and he was discharged on the second post-op day.
Yes, but do you think the amount of drainage just
it was only 70 ml? It was only 70 ml. So
yes, that's what I'm talking about. Even though you saw so much using, this space is not a problem for bleeding. You have a huge problem for bleeding, as plastic surgeons have shown a lot. When you use a mesh in the subcutaneous space, onlay mesh, and you have a lot of oozing, then you need a drain, because subcutaneous space is really a trouble. But this space, this preperitoneal space, is a very, very friendly space for the surgeon. So I guess maybe you should not need this drain, as you have shown that it was just 20 ml of drainage.
It was a deviation from the normal course, so I just wanted to be better safe than sorry. So,
yes.
But yeah, nowadays I hardly keep drains in the retrospective space.
Anyway, congratulations on your case.
I think that's a wonderful video, Pinak, and I always keep training people and tell them that as a hernia surgeon, always try to preserve the peritoneum because it's going to be your rescue measure. Leave the tigers to the government of India, they will save them. But as surgeons, we should always save the peritoneal sac. Yeah. So let's
I agree, and I think it reminds us the revived technique of peritoneal flap for incisional hernia, because we used to cut the peritoneum out and then deal with the defect, but now we know that we can get some assistance by natural tissue.
Thank you. Always save the peritoneum. Always save the peritoneum. Thank you. Next video. Tarun, can you unmute yourself?
Now the next video is by Dr. Mukund Khetan, surgeon from Sadangaram Hospital, about lateral optical trocar entry with superior crossover. And Dr. Rakesh Gupta sir is the expert panelist. Over to you, Dr. Mukund.
Yeah, thank you, Tarun. So here, this is nothing an innovation, but a sort of an innovation and technical consideration while we do ETAP RS with a TAR in one of our patient who is having, she's having an infraumbilical incisional hernia scar with an semilunar line defect also. So can I have the video play? So it's a lateral entry at the level of semilunar line using a 5 mm optical trocar. And as soon as we enter and see the rectus muscle, we obliquely make the trocar move towards the umbilicus, almost parallel to the abdominal wall, so that we don't pierce the posterior rectus sheath, and we enter the left retrorectus space between the rectus muscle and the posterior rectus sheath. And then the second trocar is placed about 4 finger width, that is 6 to 8 centimeter below the primary trocar at the level of linea semilaris, and start dissecting into the left retrorectus space. Here, because of a incisional hernia in the infraumbilical part, you can see the adhesions of the rectus muscle to the posterior rectus sheath. So here one have to be very careful so as to prevent the opening of the peritoneum, because if the peritoneum opens up at this point before crossing over to the contralateral side, then it becomes a mess in a ETAP RS repair. And once we have done the lower dissection, then we do a superior dissection between the rectus muscle anteriorly and the posterior rectus sheath up to the level of the costal margin, superiorly, laterally up to the level of linea similaris, and medially, where you can see that the posterior rectus sheath is climbing up and joining the linea alba. And then once we have done this dissection, then we introduce an epigastric trocar. So this trocar can be high up. If we start initially with this trocar, we might be either close to the linea alba or we may be a little lower down. So here this will help you in dealing with and doing a crossover a little higher up. And then a posterior rectus sheath is divided medially about 5 millimeters below the level where it is attaching the linea alba. And as soon as you divide this, you should be seeing this fat, which is basically a preperitoneal fat pad or falciform ligament, and dissect between the falciform ligament and the linea alba, preventing injury to the linea alba. And as soon as you go laterally, you will see a brownish fibers seeing through the posterior rectus sheath, and then make a nick into the posterior rectus sheath to see the longitudinal oriented fibers of the contralateral rectus muscle. And once you see that there are longitudinally oriented fibers are seen, that means that you have entered into a right plane, that is the contralateral retrorectus plane, dissect between the rectus muscle and the posterior rectus sheath, and enlarge your this opening to introduce your fourth port. And once this fourth port is there, now the camera is shifted to the epigastric port, that is the 12 mm trocar, and the dissection started in a craniocaudal direction, dividing the posterior rectus sheath on either side where it is attaching to the linea alba, preventing injury to the linea alba. And as you go down, you dissect the contralateral retrorectus space, that is the right retrorectus space, preventing injury to the linea similaris and the neurovascular bundles which are encountered laterally, and also to prevent any injury to the linea alba, because one should not try to remain very close to the linea alba, otherwise there may be a buttonhole injuries or some injury into the linea alba which will get unnoticed, and if not covered by the mesh, then can lead to a recurrence. And as you go down, as you encounter here, you can see that the muscle is attached to the posterior rectus sheath. So you have to be very careful. But once you have done a crossover, even if the peritoneum opens up at this point, it is not going to reduce the pre-peritoneal or pre-posterior rectus sheath plane. And if you see that there is bowel over there in the contents, one can open the peritoneum over here, do a diagnostic laparoscopy as we do in IAPOM, reduce the contents, and then do your rest of the procedure. So here we are going down, and as soon as we go down further, we will encounter the midline defects. And once the midline defects have been dealt, then you see in the suprapubic part, as there the posterior rectus sheath is deficient, most of the time you will see that both the recti are converging to each other, and you will not see any linea alba over there. So this is just about somewhere think about a lateral entry so that you can place a trocar higher up in the epigastrium for a superior crossover.
Thank you, Dr. Mukund. Yes, Dr. Gupta, I think. Yes.
Thank you, Dr. Ketan, for nice presentation. I think I always teach my resident that accurate knowledge of anatomy is paramount to understand this kind of procedure, and you showed wonderfully how to go in this space. And one very important point, that when during the crossover, we should not stay very high to damage the linea alba. And for the crossover, I mean, what I do, I make a space on the right side first. So first on the left side from to the camera, then same procedure I do on the right side. So sometimes it's difficult to find the posterior rectus sheath contralaterally. So if you make the, I mean, this is one very small trick. You can create the space on the both sides.
This is like a shake hand. So you can shake your hand, the left and right hand, doing the two separate dissections. But with experience, what I have seen is, if you see the contralateral posterior rectus sheath, clearly the linea alba is a wide glistening structure which will not show any fibers. But when we go laterally on the opposite side, you can see either the fibers of the transversus abdominis vessel, which is encroaching medially, more medially, superiorly, or you can see the fibers of the contralateral rectus muscle through them. So those are appearing a little more pinkish than the white, as the linea alba appears more glistening white.
Mukund, that's a very nice depiction, and just what I would like to share. What we do is we make both the areas when we're training people on right and left side, and with the side where you have your assistant, we do the tapping technique. So we just tell them to keep on tapping onto the highest point of PRS. You can see from the opposite side, and wherever he's tapping, you can go and make a nick. This is a very useful and a very simple jugaad. You just have to keep on tapping it, and you can see, okay, this is the area of the apex. You open up there, you will never ever go wrong. So this is just one suggestion. A wonderful video, Mukund. I think we can go to we have got last two sessions remaining, last two videos. Let's go to the next, Tarun.
Yeah, now next speaker is now Dr. Praveen Sinde from KM Hospital, Mumbai. This technique is trans-illumination technique for IPOM. And Dr. Naeem is the expert panelist. Over to Dr. Sinde.
Hello, good evening, everyone. Thank you, HSI, for giving this opportunity. I'll be talking about trans-illumination technique in IPOM, which is important to prevent bleeding. Can you please play the video? Yeah, so I'm Dr. Praveen Shinde. I am from KM Hospital, Mumbai. And this is about trans-illumination technique in IPOM. So as you can see in this image, the abdominal wall is richly supplied by vessels, which you may encounter during IPOM while you are tacking the mesh to the anterior abdominal wall. And they may get injured accidentally. And if you have a patient with cirrhosis or portal hypertension like this, these vessels, your problem is double-fold. And you're not always lucky to have this kind of situation where the vessel is so clearly visible. You can see this pulsatile inferior epigastric, so nicely seen. Not always the case. So it is better to have a road map so that you know where to go and you also know where not to go. So with this idea, we have a road map for a IPOM to prevent this complication of bleeding. So we have taken this concept from the trans-illumination of the veins by the vein finder. You can see in this image. So this is our technique. We call it as mark in dark. So this is a patient undergoing IPOM. We convert the OR into a dark room by dimming all the lights, and then we trans-illuminate the abdominal wall with the telescopic light, and we can see the vessels clearly, and then we mark them with the sterile skin marker. We do this on either side of the abdomen. And with this technique, now we have a road map which will tell us where not to go while you do tacking in IPOM. So you can see those lines, those are the vessels. Also, you can use this technique for the safe transfacial entry. You can see in this video, we are marking the sites for transfacial. Please make a note that we are marking the transfacial sutures 2.5 centimeter away from the mesh edge, so that the mesh sits very, very nice and very, very flat on the anterior abdominal wall. And after doing this, we can again apply the trans-illumination technique, what I showed you before, and then you can go from the avascular point. So after doing that, you can see the mesh sits very nicely and very flat on the anterior abdominal wall. There is no folding of the mesh. And please note, there is no bleeding which occurs at the tack side. You may have a little minor bleeding, but majority of times we're able to prevent any kind of bleeding in IPOM, which can be really troublesome to control. So maybe in the future we are able to use this kind of infrared light. Maybe we are able to incorporate them. Thank you very much from KM Hospital, Mumbai.
Thank you. Praveen, over to Dr. Naeem, sir.
Yeah, thank you, Praveen. That's a very intelligent way of saving the surgeons from bad bleeding. You know, IPOM is as everybody know and everybody said, that it is going to stay for a while, and definitely we'll have to be very careful about the bleeding. And your technique definitely will help the surgeon to prevent bleeding from either tackering or suture passage. I really congratulate. That was a very, very nice.
Thank you, sir. Thank you. I have learned this technique from Dr. Gandhi, who I used to work with him about in 2015. And I really
that's
want to
great.
thank him for teaching me all these points, finer points, which prevent all those complications which can be really troublesome especially in private practice.
Definitely. That's great. Very good. Thank you.
Any other comment from the panelist? Any other technique which the panelist uses other than this?
No, I just want to congratulate again because, as Nain already said very well, I guess IPOM is gonna stay a little longer among us, and we should know how to do it in the less troublesome as possible way. And Nain, it's great to be with you again. We have been together a few days ago, amazing mini webinar, and now again, it's really a great pleasure for me.
Yeah, thanks.
Good to see you again.
Good to see you. Yeah.
Any other panelists, sir? Anyone?
Praveen, just one question. What is the intra-abdominal pressure you keep when you're marking those vessels?
It is normal. I mean, what we keep it, the intra-abdominal pressure, we keep it at 14. We don't change it.
So when you tack, do you change the pressure? So normally we say that you bring down the pressure to 8 millimeter or 10 millimeter. But when you tack, do you change the pressure now?
No, not really required. In my opinion, not really required.
Thank you.
Yes, so I think let's move to the last batsman, and he's an expert. So Tarun, can you introduce our own Ganesh?
We have kept our
I'll share the screen now, Jignesh. Thanks for your kind words.
Dr. Ganesh, he's our Sachin Tendulkar, but he's coming bottom down now. And so we will request Dr. Ganesh from Bangalore to present his video tap without flap. And Dr. Ramesh and Dr. Jignesh are expert.
I'll share the screen. I have a edited video.
So we have it, sir. Anmol will share, sir.
Yeah.
You can do it.
Okay. This is a bigger video.
Okay, so do you want to share, Dr. Ganesh?
Yeah. I just want to share the video.
Yeah, okay, fine. Anmol, I think we can stop here. Let him, because he's the last man.
I'll share.
Give all credit to the Sachin Tendulkar. He can use the right-sided, he can bat from left. He's
a retired Sachin Tendulkar. In this era of he can become the 20th batsman. It's a T20 cricket.
Go ahead. Go ahead, Ganesh. Go ahead. Please go ahead.
Share screen. Share.
I think we'll have to give him the host rights. Yes, please go ahead. We can see your screen.
Guys, sharing, sir.
I'll proceed, Jignesh.
Yeah.
Thank you very much, Dr. Ramesh, sir, Jignesh, all members of Hernia Society of India. I don't know whether to call it as an innovation or a gimmick so this was basically a patient with a bilateral inguinal hernia. So planned, right side was the inguinoscrotal hernia, and he was planned for a laparoscopic bilateral TAPP repair since there was an inguinoscrotal hernia. So the right side dissection is done. On the left side, I didn't raise the flap. So basically, it was a one-handed dissection. The space of radius was already defined. So on the left side, with the single-handed dissection, the space of radius on the left side, including the Cooper's ligament, were dissected. Then the exact plane, that is the two layers of the fascia transversalis, were dissected, reaching the space of Bogros laterally using one hand with the one single instrument. So that's the medial part of the dissection. You can see the Cooper's ligament there. The space of radius is entered at least 2 centimeters. Those are the cord structures. So all the fibers are dissected. There's the external iliac artery there. So basically it was a traction, good traction by a left hand and dissection by the right hand. So that's the triangle of pain. You can see the nerve there, you can see the psoas muscle. Now, after I completed the medial and the lateral dissection, I proceed with the dissection of the cord structures. So the vas deferens and gonadal vessels are separated. There was a lipoma of the cord. So as a rule, all lipoma of the cords needs to be reduced. So the lipoma of the cord was reduced. So my intention here is to do the tap repair without raising the flap on the other side and without compromising the critical view of my pectoral orifice. So there's a completely dissected area. So this patient had a small direct hernia, a lipoma of the cord. So this is the complete view of the myopectoral orifice. So as you can see here, we have not raised the flap on the left side and we have not crossed the medial umbilical ligament also. So here another jugaad is to create a preperitoneal space. The trocar is pulled back into the preperitoneal space and the meridian is passed. Then the space is created so that there is enough space for the placement of the large mesh. A 12 into 15 centimeter polypropylene mesh is placed and tucked well into the space of Retzius after the right side mesh was placed, and care was taken not to roll so that the mesh doesn't roll. So mesh was placed flat and fixed with tackers to the Cooper's ligament and the mid-length crossover of the two meshes and the rectus muscle. The peritoneum was also tacked laterally on the left side and the right side flap was closed. So left side it was a tap without raising the flap. So I thought to name is tap without flap. So that's the completed dissection.
Thank you, Dr. Ganesh. Dr. Ganesh and Dr. Ramesh, sir, any comments?
Yes, Ramesh, sir.
So suppose, Ganesh, you had an indirect hernia on the side which you did not raise a flap.
Yes.
Wouldn't the dissection be a bit more tricky and difficult?
Definitely, sir. Definitely a bit more tricky. I feel that patients who have a small direct hernia or a lipoma of the cord or a incomplete indirect sac, this technique can be tried. But a patient who has a complete indirect hernia with lot of chronic indirect hernia or lot of fibrosis between the cord structures and the sac, this technique might be quite a challenging one.
So you have to choose. You have to choose your patients well. Yes. You can't apply for all. Good.
And you require a very good 30-degree camera assistant for this case because to show the lateral part of the dissection, it requires an expert 30-degree camera assistant.
Yes,
Ganesh, we always keep the best for the last, and that's what you have proved. Do you think, because this jugaad just came in my mind, that the use of a 45-degree scope, which we use for beta, would be very useful in this kind of a jugaad because,
I agree with you because, yes,
very well.
Yeah. The space of Bogros visualization and the laterally as you go above the anterosuprailiac spine, it will be better visualized definitely by a 45-degree scope.
Okay. Yes. Danny, you wanted to make a comment, Danny.
Yeah, I think you can call this presentation tap through the tap because you, on the left side, you actually did a tap.
Okay.
Dr. Jignesh, can I make a comment over here?
Yeah.
Dr. Jignesh, Dr. Ketan, this side, can I make a comment?
Yes. Yes.
Like this is a technique which I usually do for my most of the bilateral taps. I make a single flap and do a dissection on the contralateral side, whatever is the size of hernia. But I do a little modification of my trocar placement. So I usually do it from the left-sided flap for a bilateral hernia, and I place my scope a little higher up in a subcostal palmar's place, a right trocar in the umbilical region, and a left trocar as lateral as possible from lateral to the linea similaris. Raise a left-sided flap, and then the scope can go down and show from, because the camera person is quite away from you. So this modification I have done, and I have done a quite good number of maybe 25-30 cases doing a single flap bilateral TAPP.
So I think we end this, the 20 jugaad sessions here, and with the chairman of the president, sir, we have about 4 or 5 questions. We have already shot over the time because of the excitement. We've been here for last 2.5 hours, and not even I can see a wink from anyone's eye. Everyone has been very attentive. So, President, sir, do you think we can take 3 or 4 more questions from the audience?
I don't think time should be a constraint. If everybody's game, we can carry on and stretch it for another 10-15 minutes.
Okay, fine. So
it's been excellent.
Yes. Yeah. So I have got some questions coming in, and there are some questions for the presenters and some questions even for the expert panelists. So let me start with the first one, which is for Danny, because one of the delegate has mentioned that you talked about fixing the mesh to the abdominal wall. Do you adopt the same policy even in a geriatric patient where you have a very thin muscle mass sometimes? So what are your views on that? Can you unmute yourself, Danny, please? Can you unmute yourself? Thank you.
I think it doesn't really matter because we talk about anatomic planes and not thickness in millimeters. So if I pass the suture and tie it subcutaneously and it takes the fascia, that's enough just to hold the pseudosac in place.
Okay. Dr. Gustavo, there is a question for you. You had mentioned somewhere about your insights on use of intragastric balloon procedures. So can you just enlighten us on that, intragastric balloon?
Intragastric balloons is for obesity, and we have used it in preoperative preparation for some extremely obese patients who have a hernia and have no indication, or at least they do not have desire to have a proper bariatric surgery that would be the proper procedure for them. So if a patient loses like 30 kilograms or 25 kilograms before hernia surgery, it's a good idea, and it makes the procedure much, much easier. So what we do is we place the balloon, we wait 3 to 4 months, and if the balloon is still in place, we do the hernia surgery, and we still keep the balloon for more 3 to 5 months, and that's all. Remove the balloon, and if the patient regains the weight, we already have done our job about the hernia.
Okay. Can we have all the presenters' videos on, because the audience can see all of you at the one time. Then there's a question for Dr. Hiroshi for you. What has been the recurrence? What has been the recurrence in your technique of needlescopy? So have you had any recurrence with this technique?
Recurrence rate is about 0.4%. It is very low.
Okay. The next question is to Dr. Sadashiv. What is the largest size of mesh you have inserted by your technique, Dr. Sadashiv?
Yeah, I have inserted 20 by 30 mesh by this technique, largest size.
Okay. So you think that the rolling and then the thinning of the mesh probably
yes,
you can
yes,
very
probably we can introduce it very comfortably.
Okay. Dr. Naeem, there is a question. Do you think in future we will be eliminating the use of trans-abdominal full thickness sutures, which we're taking? So do you think it's going to get replaced with the mesh technique which people are doing to fix it, or do you think only tackers will do?
Oh, okay. Tacker and transabdominal suture passer people are using now. I mean, surgeons are using, especially in this part of the world when we are really concerned about reducing our cost. A tacker with 20 or 30 clips sometimes is quite expensive for our patients. So it's all up to the surgeon, and definitely this kind of fixation, it depends on the surgeon as well as the patient's capacity. And I believe in future also it will remain, because especially when IPOM Plus is going to stay for a while, and it just depends on the surgeon's choice, and it's nice. And we have learned really today great things, especially deciding for the marking the vessels with illumination, transabdominal, and also making a dark room in the operation theater. These are real good jugaad, and I really congratulate everybody.
Yeah. Dr. Rakesh, just one question for you. There was a panel of around 20 videos, and 19 or 18 of them were minimal invasive section. Do you think looking forward it's going to completely replace open hernia surgery? So your viewpoints on there. And then I would like to have a quick comment from Dr. Sanjay as well.
I think open hernia surgery will stay, because as we are talking about AWR, so we need to, complex AWR. So this kind of patient, we need to have, we cannot stretch the boundary of our laparoscopic or even robotic to this kind of the patient who having bigger defect more than 10 centimeter or 15 centimeters, so and having fistula, having needing large amount of paniculectomy scar. In this kind of patient, definitely we need to have some kind of open strategy. And definitely in low resource country like us, I mean, maybe 50% of the patient cannot afford to have this kind of composite meshes. So even for that kind of the patient, yes, we need to adopt some kind of open technique. So open technique will not go, especially in the complex AWR reconstruction, and definitely in some patients who are from the poor resources population in most of our scenario. And one very quick comment about the fixation, like sometimes we fix the tacker on the thin patient. So we should not push too much from the outside, because I saw a few patients having tacker on the skin. So our resident push the tacker from inside and push the tacker from inside and have given too much pressure from outside. So in the full stop, we can feel the tip of the tracker on the skin. The patient was quite thin. So that is another point of view when we fix.
Okay. But yes, sir, I would like to have your comments on, do you think how this kind of technical sessions have benefited and how it's going to benefit the young surgeon in India?
I would say first, thanks a lot for including the vision, including the thoughts. And you have done a great job. Whole of the team has done a great job. Second thing is that, yes, these are the practical lessons one learns. For example, as your institution had also presented about the trans-illumination technique, this is called as diaphanoscopy. Diaphanoscopy. If you are shining the light from within and you are shining the light from outside, and then you are able to see the vessels, this is called as diaphanoscopy. So many small lessons one learns. And whenever one goes in for doing the surgery next time, you would always remember, yes, I had seen this small tip and that has made a difference. So I think you have done a great job. All compliments to Ramesh Agarwalla and all of your team. And plus, most important, I think whose idea was this, I do not know, but you have included the international faculty who are having excellent experience, and they had excellent comments about the videos. Thank you very much, all the international faculty. Thank you. God bless you all. Stay safe.
So I think, yeah, thank you, sir. So I think we have probably come to the end of the question answer session. Before we wind up, I would like to have one take-home message from each of the expert panelists. I'll start with Danny. A quick take-home message for everyone, and then the last comment coming from the President HSI, Dr. Ramesh Agarwalla. Yes, Danny, please.
I just want to say that I really enjoyed this session. I really like all these tricks, and this is what makes surgery fun. So thank you very much for your invitation.
Thank you very much. Thank you very much. Dr. Gustavo.
First of all, I'd like to thank for the invitation. I really enjoyed the session. It was great time to be with you. I have learned a lot today. And this is just the opposite of most of the people are talking about evidence-based medicine. But we are seeing what is image-based medicine. We have seen images that really touches our heart. And when we see something that is really good, you don't need a prospective randomized trial. Just say it's obvious. I want to incorporate this in my practice, just like unrolling the mesh. You don't need to do a 200 cases unrolling the mesh one way, unrolling the mesh another way to see that this is a good trick. So this is something that you need to understand, that surgery is much more than just science. Surgery is a perfect mix of science, art, and sometimes witchery. That's what we saw in some of the videos today, was pure witchery. And it's the magician working. And I really want to thank you again for the amazing time I have been here. Thank you.
Okay. Dr. Gupta?
Thank you, HSI team, for inviting me and letting me learn a lot about the new technique, what we call Jugaad. And definitely I will practice few of things, and I will teach my resident the few techniques which I learned today. Thank you, whole HSI team.
Thank you so much. And Dr. Naeem, sir?
Thank you, Ramesh. Thank you, Jignesh. Because in this COVID era, one good thing has happened, that we really learn how to interact nationally, internationally, with a number of people together on online. And this is a great event what Hernia Society of India has organized, and I feel honored and really happy for being a part of this. And I really think in this part of the world, especially, Jugaad is important because, well, it is indigenous and we need to learn how to cope with the situation, how to help our people, even who cannot afford a lot of things, but surgeons should learn how to help them out. And thank you very much for this interactive session. It was truly a real interactive session. And starting from Parvin Vatia to the last speaker, the Ganesh, every talks were really great and really innovative and enjoyable. Thank you very much.
So Ramesh sir, before I come to you, the whole backbone of this program was Dr. Anmol. Anmol, can you come up on the screen? And Anmol and Tarun they really tolerated me for the last couple of weeks. We've had a lot of exchanges through and through. And I can tell you, Anmol in himself has been doing wonderful work, and he's got a lot of jugaads. But because he was a part of the organizing team, he could not present his work. Anmol, would you like to say something, please? Anmol.
I would like to thank everyone who has participated. See, this whatever we have done in past few days, ultimately this program has become success because of your participation. You are the actual stars of this program, and I'd like to thank you all. And for me, it is very easy to work because I have very hardworking seniors with me, like Dr. Tarun Mittal, who is himself a very hardworking person. So it becomes very easy to work. And same is with Dr. Ramesh Agarwalla and Dr. Jignesh Gandhi. And yes, we have learned many new things, but yes, I'm very jealous of Dr. Gustavo. I've messaged that thing. He's doing this webinar.
Like a bitch.
Yeah.
He's enjoying.
Yeah,
yes,
he lives in a beach, right?
Absolutely. So we come to an end. Ramesh sir, your last comments, and then we can close this program today.
Jignesh, I think it could go on forever. It's excellent. First of all, I should thank you very much. I would like everybody to know it was Jignesh's idea. Jignesh came up with this brilliant idea. I had nothing to do with this program except give him a green signal and said, "You're the boss." And I would like to thank Tarun and Anmol, who pitched in together, and they really put in so much of effort to bring this together. It's amazing to see so much of talent is there. We just have to tap the talent, so much of innovation, so much of talent. I'm very grateful to all the faculty who have really put their pearls of wisdom. And we all are going to gain quite a bit from this. And we always know necessity is the mother of invention. We can say that we are, developing countries and we need jugaad. But I can tell you the Western world also equally needs jugaad. They are also short of finances. They also want to cut down costs. And they would also want to know different techniques where they can cut down costs or they can improvise. And this is applicable not only for our country or to the developing world, but I think it's good for the entire world. And the most of it is all our patients are going to gain by this, which is very, very important because we are all very patient-centric and our only aim is that the patient should benefit. So I thank you all for this exciting session. I am really, really very impressed and very grateful to all of you. Thank you very much and good night.
Good night to all of you.
Thank you.
Stay safe. Thank you.
Thank you, everybody. Take care. Good night.
And I would thank Kritika and the Docplexus team for, always backing us up. And always we are spilling over. We have a 2-hour program. We go into a 3-hour program. And they never make a fuss about it for extending the time. Thank you very much, Kritika and Docplexus.
Thank you. Thank you, sir.
Thank you.
Thank you.
Bye-bye. Good night.
Thank you. Bye-bye.